Now I'd like to invite Dr. Nabeel for cataract workup for postgraduates.
Good morning to one and all. So my talk is aiming at cataract evaluation and a bit about biometry, and mainly for residents. I have no financial disclosures to be made. So for chief company, the actual evaluation starts with history taking. And we must learn the art of listening because sometimes the complaints might not be related to cataract per se, but can be relevant for patients. Anything like itching, foreign body sensation, we have to listen to that and try to address that as well. Now, in the history of presenting illness, we must inquire about the onset, if it is definitely diminution of vision because of cataract. We need to know whether it is painless or with pain, and we need to know the nature, which is whether it is progressive or stagnant. We need to know about the treatment history. Hypertension, very important. We need to know about diabetes status, thyroid-related ailments. We need to know about CADs because patients may be on blood thinners. And not very important for topical surgeries, but for block, we tend to stop ecosprin for 3 days and clopidogrel for 5 days. We need to know about BPH because patients on tamsulosin and Urimax may have intraoperative floppy iris syndrome. And your planning changes. Your incisions are more corneal, long tunnel length. You might have to use a pupil expansion device. You want to know about rheumatoid arthritis because that can be associated with AC reaction and cells. You need to know about steroid intake, oral, topical, local, everything. And you need to know whether the patient is taking treatment for glaucoma because ideally we should stop prostaglandin analogs before surgery for the washout period, which may be 2 to 4 weeks. Past history is very important, and leading questions might help here. Please ask about previous ocular surgeries because if you don't ask, patient might not mention about refractive surgeries. And everything changes because the biometry changes completely. And you need to ask about trauma. When I see a white cataract in a younger patient, I do ask about trauma, diabetes, and recent intravitreal injections. Very important. You need to know about personal history. Addiction, important because smokers don't usually get the effect of the block very early. Coming to general examination, you would want to see the pulse rate. Shouldn't be very tachycardic. Blood pressure, if it is high, you need to treat that before surgery. And saturation. Now coming to ocular examination, you need to document the visual acuity. Both uncorrected, best corrected, and vision with pinhole, very important. You need to document IOP, preferably with a non-contact method. You need to document the head posture. Do not directly jump to cataract examination. Do see the lids and adnexa. At least do a Roplast test if not syringing. Do document if there's any deviation. Could be sensory exotropia because of hypermature cataract, or could be a pre-existing deviation. Do document extraocular movements. Coming to slit lamp examination, please examine the conjunctiva quite well. If possible, evert the lid. Do examine the palpable conjunctiva as well. Many a times the patient might say they have a foreign body sensation, and you might see a small foreign body hiding in the sulcus subtarsalis, so that becomes important. Do examine the sclera because it's a tendency we sort of jump to cornea examination when we see a cataract patient. Do examine the sclera as well. Cornea, very important. And corneal examination should be methodical. You should see the size of the cornea, the sheen, the transparency, if possible, sensations, and do a specular reflection to assess the health of the endothelium. Do examine the anterior chamber for content, cells, depth, iris for any neovascularization, any pigments, any cysts for that matter, and pupil. Please do not directly examine the patient for cataract surgery when they are dilated. Many times what happens, they are dilated before they are brought to you. Do see them undilated. Document the pupil size, pupillary reaction. If there's any anisocoria, do document that. And pupil size becomes very important. If a patient has senile miosis, might not be a favorable patient for multifocal implants and EDOF sometimes. So that becomes very important. Do document as to how much is the dilatation. Because the surgical planning changes. If patient is dilating only 4 mm with all your pharmacological agents, it becomes important. You might need a pupil expansion device. You might need iris soaks. You might need rings for that matter. And do document as to how much the patient is dilating. And then comes the cataract grading. So the latest grading that is being followed is LOCS 3. So color coding is there. So what we usually do is see on an oblique illumination, we see the color of the nucleus. So the trick is GYABB, grayish, then yellowish, then amber, brown, and black. And for cortical and posterior subcapsular, do a retro illumination and grade according to the guidelines. Do document if you see a posterior polar cataract. Then again, the planning changes, the surgical method changes. Some things are to be avoided. Some things are contraindicated. And your planning changes. You need to have a 3-piece IOL as a backup. You need to have anterior vitrectomy setup and all. Particularly important is the type 3, where you see a diagnostic sign. The white dense spots are grayish spots on the posterior capsules are quite risky because they are often associated with extreme thinning and pre-existing defects sometimes. Do examine the anterior vitreous. There could be vitreous opacities, floaters, asteroid hyalosis. Coming to fundus, we most commonly do it with a 90D. Some people do it with 78D. It's completely all right. And if possible, do an indirect ophthalmoscopy for periphery, because many times we don't see the periphery, but some lesions can be present, particularly if the patient is myope. Coming to investigations, do a macular function test. So there can be many, like Amsler grid, photo stress test, 2-point discrimination test. If possible, do an OCT macula, but that can only be done when the media is relatively clear. In opaque media, completely opaque media, white, mature, hypermature cataract, and very dense cataract where the fundus is not visible, you can go for ultrasound B scan. Document the counts with specular microscopy, but then again, it comes with a cost. Not every practitioner would have this machine. So therefore, it's very important to have a specular reflection view on the slit lamp. Do a xylocaine sensitivity test if you are planning the patient under block. For investigations, blood sugar, fasting, and postprandial is important. And I personally go for viral markers as well, but then some people go for it and some do not. And biometry. Biometry is something, many a times what happens is the biometry is being done by residents, although the number of cases are more done by the consultants. And we don't pay good amount of respect and the time to biometry which is required. So we need to have some basic understanding of biometry. So let's do that scenario wise. Case 1. So you can see the K values are in the normal range. The AC depth is in the normal range. The lens thickness is in the normal range. The axial length is in the normal range. Nothing unusual. And for calculation purposes, I have taken A to be 118, A constant to be 118.8. SRK formula gives, for emetropia, it will give around 20.44. SRKT will give 20.62. And Barrett Universal 2, which is a 4th generation formula, quite well accepted now, will give around plus 20.37. So for this particular patient, aiming at emetropia, I would probably put a plus 20.5 IOL, with the steep axis planned at 101 degree, because that also needs to be accounted. There's a difference of 0.25 diopters for the K values. So what's important here is for normal values of the indices in biometer, all the formulae will give nearly the same results. But see a second case where the K is very steep, and here SRKT will fail. There's a difference of around 1 diopter, and 1 diopter is good enough to surprise you and the patient. So I would prefer a Barrett Universal here, because SRKT has a limitation. It underperforms in steep case and flat case. Case 3, the K values are normal, but the axial length is a little less. It's a short eye with a normal AC depth. So there's posterior shortening. And here also SRKT will underperform. You can see a difference of nearly 2 diopters. So we need to know this, how to select the formulae. For very short eyes, that is axial length less than 20, we would prefer Holiday 2 and Hoffer Q. For short eyes, axial length 20 to 22, we'll prefer Hoffer Q. For normal axial length, SRKT, Hoffer Q, Holiday 1 gives good enough results. For long eyes, nearly 24 to 26, we prefer Holiday 2. And for very long eyes, more than 26, we prefer SRKT. For steep case and flat case, we avoid SRKT. And effective lens positioning or effective lens position is best predicted by 4th generation formula, which is Barrett Universal, Haggis L, Holiday 2. So coming to special scenarios, if you have a refractive surprise and you are planning a piggyback IOL, so for myopic surprise, whatever refraction is coming, you multiply it with 1 times the refraction, and you get the power to be implanted for piggyback IOL. And piggyback IOL is a sulcus IOL, 3-piece IOL placed in sulcus in front of the IOL which has already been placed. If the refractive surprise is hyperopic, you multiply with 1.5. So 1.5 times the refraction, you get the value. Very important for sulcus IOL. If you have a PCR, you do an anterior vitrectomy, you have cleared all the vitreous. Now you want to place a 3-piece IOL in the sulcus. So whatever power you have calculated for the bag, in the bag placement, so what you need to do is, there's a rule of 9. For 0 to 9 diopter, you do not reduce any power. For 9 to 18, you reduce by half. For 18 to 27, you reduce by 1. And for more than 27, you reduce by 1.5. Provided you have accounted for the A constant, because A constant difference will also have to be accounted. If the A constant for this particular IOL is half diopter less than the one originally planned, then that also has to be accounted. For scleral fixated IOL, usually in the bag IOL power fits well, because SFIL anyway sits quite posterior. For vitrectomized eye, usually we prefer to increase the power by 0.5, because when the vitreous is not there, the aqueous is there, the PC sits slightly posterior. For triple procedure, so you're aiming an open sky procedure, PK, cataract, and IOL procedure. So what you're doing is generally taking the K values from the other eye and doing an ultrasound biometry for this eye, for axial length, and you calculate it. Most important in today's world is post-refractive surgery. So what happens is, in RK eyes, you do see during the examination, but a LASIK eye can easily be missed on examination if you're not careful and the patient is not telling you. I've seen sir operating a lot of RK eyes, and we used to do the calculations together. So it's and the surgical planning also changes in RK eyes. You don't have to intersect the incisions, the wound is a little scleral and all. So what I believe is, today we are seeing more of RK eyes, but 10 years down the line, when probably I become a senior surgeon, then I would be facing more of post-LASIK eyes. And it's important to consider that normal formulae, normal consideration will not apply to this. For myopic LASIK, you will end up with a hyperopic surprise. So you need to have topography, tomography considerations. And the formulae will be Barrett, Truquet, Hagizel, and AI-based formula like Hill, HRF, and LADAS super formula. Thanks.